I think often people are putting up with this for a long time before they're coming to see us. So they're at the point of exhaustion. They're at the point of it's impacted them so much. Hello and welcome back to another episode of New School OBGYN, the podcast about women's health, but for everyone. And we're back with Dr. Valieva.
Yay. It's been a while, Eric.
It's been a while. And we might be a little out of practice once again, but...
Sorry.
So many people are affected by pelvic pain in their lifetime. And hopefully this video can help them because we're going to do a general overview of pelvic pain in women. And we're going to cover a number of different things in overview and eventually go over things like, in a different podcast, things like endometriosis, which is a big keyword. But in this one, general overview. And so once again, Dr. Valieva is a board certified OBGYN, just like myself. And shout out to people taking boards today. It's a big boards day, including one of our partners, Tiana. Shout out. Thank you for following along. We're also on YouTube. Check us out there. All right, Olga. So pelvic pain can be in a number of different ways. It can be acute, meaning all of a sudden it happens and it's short lasting, but can be severe and impacting. Acute pelvic pain lasts for less than 3 months, they say. So we encounter this a lot, and there can be certain emergencies for this, but that's not going to be a majority of our talk.
Right.
Majority of our talk is going to be about chronic pelvic pain and the significant impact that it can have on people. Chronic pelvic pain is longer than 3 to 6 months. It accounts, and it can impact potentially a quarter of women in their lifetime. And chronic pelvic pain, that wouldn't be like pregnancy-related pain.
Right.
And so it can have a severe impact on someone's life, whether that's physically, emotionally, socially. Might not want to get out, do the things you normally do that bring you happiness, and that can have a snowballing effect for mental health along with all the pain. But someone is coming to your office. They have a history of pain within the pelvis, which basically would be like belly button down,
right,
or probably a little lower than belly button. And it's been ongoing for 3 to 6 months. We could just start with the like how we're going to evaluate, but actually, how can a patient better, help their provider figure out what's going on? What can they do beforehand? What information can they give you to help in their diagnosis?
That's a good question. We used to send out questionnaires, but I feel like nobody ever actually fills those out.
Unfortunately.
Which is helpful for them to think about things I always ask, like, when did this first start? Do you remember anything happening to get this going? Because sometimes it's just this like little thing that happens once or twice, and it starts to happen more often, and people don't necessarily have a general idea of what happened or when something happened, but just how long has it been going on? What provoked it, if you can remember? How often is it happening? What makes it better? What makes it worse? Like the usual.
So the onset, the frequency, the provoking factors. We want to know that. Because I think that sometimes when you're in pain all the time, you kind of just forget.
Like you learn to live
how
with
did it start? Or like you forget the details, and it's just like I'm in pain all the time, or certain parts of the week or month.
And some people have this like, oh, I remember like exactly when this happened, and ever since then it's been this way. Or I think for majority of people, it was like, well, some maybe just start with my periods, or it started with a bladder infection, whatever, right? And it just becomes this long drawn out thing. So kind of like how, and I don't know if all women do this, a lot of women I think do, like keeping like a menstrual calendar. People could keep a diary of symptoms, like what happens, what might come up, when it could come up. I don't know if a lot of people think about dietary, lifestyle, exercise type things that potentially could have happened or are happening that could be impacting that as well. So those are questions I always ask too. One thing that I know a lot of people potentially might not be comfortable, but always ask about history of trauma, not necessarily like sexual or physical, but just even like falling as a child or being in a bike accident, whatever, right? So that can definitely impact it. And I think those would be some things people could think of before coming in, just to kind of give them an idea and give me an idea of what could be contributing.
Yeah, exactly. I mean, there's, like you mentioned, documenting menstrual history is something we're definitely going to ask you about. And a lot of times you can just have that available on your phone on an app. And all that information would be helpful. And so, yeah, someone's coming to us now in their first visit seeing us. I think, you know, generally patients, at least when I see them, they're tired, they're exhausted of this. They've been maybe dismissed a little bit in the past by other providers, or they're worried about being dismissed with their symptoms. And so I think there's just kind of sometimes a nervous energy when seeing patients with a history of chronic pain for that first visit. And so we're going to ask you a lot of those questions that Dr. Valieva kind of said, how long has been going on, what provokes it, are there certain, things that happened to you in the past. And so the more information you have, the better.
Yeah. And I know this is an uncomfortable topic for a lot of people, and I just want to encourage patients to be as open and, what's a good way to say it? Like, don't be embarrassed about don't be embarrassed about what's happening. We're not here to judge you. Just, I want to know what's going on. So if we're asking questions about like pain with intercourse or pain with bowel movements, or not maybe everybody asks, but I'm like, I actually asked, what does your poop look like? Like, I want to know, right? This is weird, but they're helpful to us to figure out if there's other causes or what else could be contributing to this. So be as open as you can. Give us the opportunity to like get to know your pain, if you will, so that we can better help you with your pain.
And I think, sometimes potentially like we're asking you all these different things. Someone might feel like we're getting a little away from like some people might have like, okay, I'm coming in, I'm in pain. It's likely endometriosis. But if we talk to you about your bowel habits and things like that, we're trying to gather more information. We're not saying necessarily we don't believe that you might have something like endometriosis. That's yet to be, we just are gathering all the information. Right. And so a lot of these times with chronic pain, it's not all, it'll take potentially multiple visits. Potentially referrals to get to the bottom of what's going on. And then we might do an exam at that initial consultation. Maybe even we might not do an exam.
Yeah, it really kind of depends on what we hear and what what feels beneficial at that moment in time.
What's our once we hear your story, what's our leading diagnosis? And so if you're suspecting a source of pain within the pelvis, what would an exam look like for you?
So I always warn patients that it's a little bit of a different exam for unlike a normal pap smear or a CT check or whatever. So I typically don't start with a speculum. I'll do just general looking at the outside tissue and just doing like a touch test to the outside. And then just with one finger, and I don't know if you do things differently, but just kind of putting my finger in the vaginal canal and just seeing if there's just by basic touch, if there's any discomfort with that. And honestly, oftentimes you can kind of tell how just with that one touch, how people respond, if they like recoil, if they tense up immediately, I can kind of assess how bad it is, right? And then I go a little bit deeper. And actually, one of the first things I do is I start feeling for the pelvic muscles, like, the perineal muscles, the obturator, like, the PC muscles that people call them, right? And then I kind of move up towards the bladder to see if there's any bladder stuff. And then I feel a uterus, if they can tolerate it, the uterus and the ovaries, right? But oftentimes, I don't even get all the way to the uterus because, like, the pelvic muscles themselves just stop me. And I'm like, okay, well, we need to we have an answer for the time being, right? So, so that's what I usually do. And then, depending on what I find there, if there's no pelvic muscular or like touch findings, if you will, then I'll take a look inside and see if there's anything else visible.
Inside with the speculum. Yeah. So initially you're kind of looking, feeling, you mentioned on the outside with either your finger or maybe even a Q-tip.
The Q-tip,
where you're trying to see if there's a sensitivity to a Q-tip, even though it's a very sensitive area to begin with, sensitivity with a Q-tip would indicate potentially something. And so that's why you're doing that. And then, like you said, with one finger pushing on different areas to try and, now,
not elicit or cause pain, but just like find
investigate it.
Yeah.
And I always warn patients like, okay, this is going to be, it's an exam. It's uncomfortable. Like for everyone, pretty much everyone, it's not ideal and not comfortable. But if we find your specific pain, let me know. It can help us identify which organ, like you said, if you're pushing on the uterus and it's causing pain, or if you're pushing on the pelvic floor. And often, like you said, those pelvic floor muscles, the pelvic floor does a lot. Yeah. And I would say I'm just going to maybe go off a little bit and let's talk about pelvic floor and the musculature.
Yeah.
Because I think...
You should have brought the skeleton thing.
I know. I just have Harry Potter and Star Wars things useful. Behind me.
Yeah. Can you like abracadabra? That's not the right, sorry.
I gave you the Star Wars one because I just wanted to respect your Star Wars. So the pelvic floor, I like to think of it, and maybe let's get your explanation of like how do you explain, like someone's never heard of pelvic floor. They think like their pain is
you're going to make me embarrass myself here. Okay.
Yeah, no, that's the point of this.
If I don't have, depending on which office I'm in, the Auburn office has a good old poster of all the pelvic floor muscles, but I essentially explain the pelvic floor.
We don't have that kind of stuff in Renton. We scrape by. I have to draw pictures.
I've seen your pictures. So I explain the pelvic floor as a bowl, right? So there's muscles that crisscross this way, and there's muscles that crisscross, different directions. And then I kind of like, this is the vagina, urethra, anus, and then we kind of like show them, with their body, with my body, what it might look like. And as far as like functions they serve, what they do for bowel movements, intercourse, urination, walking, laying, turning, whatever, childbirth, right? So that gives maybe hopefully some pictorial idea of what we're talking about. In Covington, we do have that pelvis with the muscles so they can have a good idea.
Yeah.
And explaining to people why this musculoskeletal component could be a cause of their pain versus assuming it's, the uterus or the bladder or the colon. Because, our pelvises are smart. And I always joke that they're also kind of dumb at the same time because it's all the same nerves from your, sacrum that are feeding your pelvis, right? Yeah. So there could be a lot of different things going on, and just showing them the structures and the muscles and how they all interact sometimes is like, oh, no one's ever showed this to me. This potentially, like, this makes so much sense. Now it's like clicking in my head, right? So I think a visual representation of the pelvis is always helpful.
Yeah. And so, and then I'll go on mine. So like, I like to think of like the pelvic floor. It's like this meshwork hammock of muscles that is an extension of the core in a lot of ways. And it kind of swoops down and controls all those openings, like you said, of the, urethra, vagina, rectum. And men, you have this too. But
why don't you guys have pelvic pain? What's wrong with you people?
We have tummy aches. Debilitating. Yeah. Sorry.
Man flu level.
Yes.
Yeah.
In one of the comments on one of the YouTube videos, I'm going off again, but someone said I should turn down my testosterone. And I'm like,
if only
I'm like, if my testosterone's so low. So the pelvic floor is this intricate like meshwork of muscles that has nerves and tendons and bones that is attached to. And it's holding up basically everything. So like gravity's on it, like all these things that move, and when someone gives birth, a baby is pushing through the stretching your pelvic floor, and
they're cute, but they do things to that pelvis, man.
And so like a pelvic floor problem can be like, oh, it's a pelvic floor problem. And that's what caused it. That's what is continuing to be the problem. Or a pelvic floor problem can be like because something else, because so much else sits in and around that area that something else being inflamed and hurt, that pain can translate over. And so that's part of it,
Does your DO brain ever come in and like viscerosomatic and somatovisceral and viscerovisceral?
For DO brain, she means we're both osteopathic physicians, and which we learned more, maybe some extra like manipulation, things like that, once in a while.
Yeah.
I think it can be definitely helpful.
Yeah. Referred pain is real, right? Like that. Yeah.
And I think another point to touch on too is that, like when someone's coming in with like the body is like really good at like telling you where pain is. Like if you get poked somewhere in your body, like on your skin, like your body's like, yeah, it's right there. But like sometimes for like the internal organs when they're hurting, it's just not as good at telling you. a lot of people come in and might say, okay, I have like an ovary pain. And it's almost like each time someone is pointing on one side or the other, potentially, or both, between that bone of your hip and the bone of your pubic bone, and like right in between there, and that's also an area of so many like attachments, and that's where your core is meeting your pelvic floor and other things. And so, it's not always the ovaries; they're not always the big bad. But it definitely, I mean, this is part of the workup. It's just one of those more common causes of pelvic pain, which I think goes under the radar, but is much more common.
And I want to stress, and I think we brought this up earlier, is be open to what we're suggesting. We're not denying that you have pain. We're not dismissing that you have pain, but I feel sometimes people just like, I know it's my ovary or I know it's my uterus, like it has to come out, but it's like there's other things than just that. Like, yes, they can mimic the same symptoms, but hear us out, like give us just a little bit of benefit of doubt that maybe like this, there could be something else there.
Yeah. And I think often people are putting up with this for a long time before they're coming to see us. So they're at the point of exhaustion. They're at the point of, it's impacted them so much, that they have a difficult time looking like opening their mind to these other possibilities. And so, don't be putting up with this for years. It deserves a workup. And so, and we might, we've been talking about the pelvic floor. And so you're talking with your doctor, you're coming up with the different causes. At that visit, there's a likely chance that you're not that first visit, going to exactly figure out what it is and immediately be able to treat it. There are some things some diagnoses, which maybe you could, but maybe on exam or, from your story, maybe we need more detail, like getting imaging. And so what would be your imaging of choice at this point?
I mean, I think we talked about this past. Ultrasound is a really good modality just to see if there's any, or I won't say organic, but any masses, growths, whatever going on, right? An MRI is also useful if you're really suspecting endometriosis, just because we can't always see those lesions on ultrasound, but ultrasound is probably an easier and also cheaper way for patients to get the initial testing. If I can't also figure it out, like when we're doing the pelvic exam, I also often collect pelvic cultures, and not necessarily for an STD, but I don't know if you do this, but I usually do like mycoplasma, ureaplasma, like, other pathogens in there, just to see if potentially they have a component of endometritis as well. So ultrasound would be the first thing that I start with as far as imaging.
Yeah. I agree with that.
I kind of backtracked a little bit.
It's a lot of times to see born patients, especially ones with, this history of pain, that, there might be an internal component to that ultrasound. You can always decline it. But that's going to be the best way to see those organs and those structures and how they're interacting with everything around them. And we might give you, like, if we really suspect this is pelvic floor, it's often it's often a multidisciplinary type thing. Like, just because, if we suspect pelvic floor, but we're not 100% sure, like this is going to completely fix everything, you probably get a pelvic floor referral. We'll teach you how to potentially calm the pelvic floor and maybe decrease its tension and its pain that it's causing. So pelvic floor PT, maybe if we suspect a GI origin, might give you a referral, or a bladder origin, we might give you a different referral.
Yeah.
That's where a lot of it, like patients advocating for themselves, patients trying to also figure it out for themselves too. Like I often say, like, if you're calling into the office because you have pelvic pain, you might not get in for a month, maybe two. During that time, kind of look at your habits, look at different origins, whether it's gastrointestinal, is someone constipated?
The poop chart. Sorry.
Yeah, the poop. Is this Dr. Amuzu speaking through you from residency?
Maybe. Yeah, I don't know. I bring up.
She's the one that had that poop chart all the time.
Scale. Yeah.
Yeah, and so do you want to explain what someone maybe
that have the poop scale on them?
I'll get you one for Christmas.
I don't. No, thank you. Actually, yes, please. So the Bristol Stool Scale, the official, I believe the English developed it, so that's why it sounds fancy. It essentially has like different types of what your stool looks like. And if you guys have never read the book, What's Your Poo Telling You? You all should. It's really delightful.
It's for kids, right?
No, it's for grown-ups.
Oh, it is. Okay.
I mean, I guess a kid could read it too, but
Okay.
I don't think the language is
thought there was
necessarily
a-
child-friendly. But
Okay.
but essentially, we go from different levels of constipation. I feel maybe I'm wrong in this, but people assume that if they have daily bowel movements that they're not constipated, right? But even if you're going every day or every other day, doesn't mean that the consistency of your stool doesn't indicate that you're constipated. So if you have like small pebbly like rabbit poos, or if you're a little bit more formed, or if they're softer and soft serve is kind of, I know it's gross, I'm sorry, but soft serve banana mush consistency is kind of what we want the ideal poop to look like. And then if it gets more water, then it leans on the diarrhea scale. So I'll actually like bring up the picture. I'm like, what does your poop look like and what color is
We'll
it?
put it in on the YouTube edit. So if someone's
Yeah.
really dying to see that and they're just listening,
It's great, but it's important.
go to our YouTube channel. Yeah.
It is. Sorry, guys, but poop.
It is. No,
poop
it is.
matters. Yeah.
Because I think I saw a number out there that like if someone's coming in with chronic pelvic
Mm-hmm.
pain, like a pure gynecologic source, which would basically be like uterus /
Yeah.
ovaries, endometriosis, is only about 20% of the
Yeah,
time.
it's not a lot.
Yeah. Between that and the bladder,
Mm-hmm.
another helpful thing that someone could do prior to their visit is there's certain bladder diets, which the bladder, has muscles in it and things like that. If they get irritated, they might spasm.
Yep.
And muscle spasming, just like if it's the pelvic floor or if it's your hamstring or whatever it is, like if it spasms, it's going to hurt.
Yeah.
Um,
I always reference kind of like, do you ever get a knot in your neck and it just not going away? Imagine
on my
like,
back the
yeah.
other day.
I mean, I was just thinking about what I have right now. So like, imagine that living in your pelvis all the time. And yes, the colon has muscle, right? Different type of muscle. The bladder has muscle. The pelvic floor is muscle, right? So I think that kind of helps people visualize it a little differently.
So making sure you're not constipated and have a good diet. You might even try eliminating some things that could be causing some inflammation. So just knowing kind of what's going in your body and keeping track of it is one thing. Another thing, bladder, taking care of your bladder, hydrating. I think hydration. Yeah, obviously some people can have a difficult time with
Let
that.
me have my coffee.
Yeah, right. Yeah, the second coffee of the day. Let's see what that's going to do to my
Does it
body.
actually dehydrate you that much?
Yeah, but
So many studies out there.
And then so you're bladder diet, changing that, getting into an exercise routine.
Yeah.
Stretching, being physically active, and doing those things for a few months, and that further is going to show your provider when you see them, like, hey, I've tried this, I've tried this, I've tried this, and that sort of helps us potentially get to a diagnosis sooner.
Yeah. Just as a little side note, maybe not a side note, the diet, movement, exercise type stuff, I really try to get a lot into this. And I think that often maybe gets overlooked potentially or never gets brought up with patients. And yes, it's nice for us to say like, yes, move 5 times a day and do yoga for an hour, like 3 times a week. And I don't know how good you are about exercising, but some days is struggle bus,
I've exercised every day for the last 3 weeks.
Good for you.
No, I'm just kidding. Not every day. I started I'm making the change myself.
No, that's good. I'm just saying, like, we get on the wagon, get off the wagon, whatever. And diet is also really important. And this is something that I personally discovered through my own health journey is, granted, I used to eat just corn dogs and hot dogs and pizza.
When you were a younger
but
gal.
my body could do it, right?
Yeah.
But finding things that there's a lot of data out there and a lot of studies on the gut health and how that really impacts inflammatory cycles and cascades within your body too. So even if there's maybe not musculoskeletal, GI bladder, but if there's just chronic inflammation in your pelvis, potentially just from your diet, that could just be it, right? And that's where you come up with the elimination diet. So doing an anti-inflammatory diet, like an anti-inflammatory lifestyle, which is really hard. I'm not saying it's easy. And also, frankly, it can be expensive. So might not be something everybody can afford to do. But if even just a little bit does go a long way.
Yeah.
And we're not crazy when we talk about this stuff. I feel like we get that crazy look sometimes.
It seems like
but,
we're off topic, but we truly believe that these things can not only help each individual know more about themselves, what's going in your body, but we're potentially finding more and more out about the origins and worsening of chronic disease, chronic pain, and so that can be certainly helpful.
This is such a huge topic, by the way. I don't think we're doing
We're
it enough
brushing
justice,
over a
but
lot of things. Like we dived a little bit into things, and we're going to go into a lot of like endometriosis, adenomyosis, things like that. We're going to a conference here in a week or two, and we might even try to podcast from the conference. So stay tuned to bring you the latest information regarding, more advanced treatments for like endometriosis and things like that. Anything else you want to add?
Yes, I feel often people are a little taken aback by the idea of pelvic floor physical therapy.
Yeah.
I don't know if we're going back to that.
We can do more of it.
It is, I can understand how if just a pelvic exam is uncomfortable if you have somebody poking around there for about an hour. Huge shout out to our pelvic floor PTs. I'm so glad you guys exist.
They're busy. They are busy with the...
Yeah. Sorry about all the referrals. Also not sorry.
No.
But it can be an uncomfortable situation. Obviously, it's a very private, intimate area, but it is really helpful. It does a lot of magic and, give it a whirl. Don't be closed off to it.
And and people think often like, okay, pelvic floor physical therapy must just be like Kegels and strengthening exercises. But actually what happens, a lot of these people who have chronic pain, there's just so much tonicity of those muscles. They're just so tight that actually strengthening exercises is probably not the right answer for you.
Absolutely.
You need to potentially do more rest, relaxation, down regulation out there, and core work is in that same respect is found as far as trying to figure out the exact word. It might be down regulating. I can't remember exactly, but there are a few pelvic floor PTs out there that are active on social media and YouTube that will potentially give you some things you could try. Maybe you could try that while you're waiting for your in-person evaluation, which is, that's going to be you still have your own primary in-person person,
Sure.
but there's some more decent information out there than there used to be for people trying to heal their pelvic floor. But yeah, and I think we can probably do a whole episode on pelvic floor, our recommendations, different things like that too. Wasn't going to, I was just going to touch on it here, but now it's sounding
There's
like
so much, Eric.
Sounds like we need to.
Yeah.
Because there's certain medications we can try,
Yeah.
compounded things. And yeah, so, check out the YouTube channel. Plenty of videos up there going up. We started a menopause, and by we, I mean I
was going to say,
talks.
I don't remember this one.
And so those are short little videos that I try to make on a weekly basis along with this. So, and along with some pregnancy related stuff too. So thank you everyone for listening. And again, this is all kind of Dr. Valieva and I just kind of talking back and forth, giving you our insight regarding how, a physician in this field might approach things. Doesn't necessarily mean each thing we say is it's not, none of it's personal medical advice. So that's why you need evaluation in person by your own doctor. All right, everybody. Thank you for listening. Have a good day, and we'll talk to you soon.
Bye.